Hello students, good evening. I am Dr. Silvaraj, a pediatric surgeon working as Professor of Surgery in a medical college in Malaysia. Today in this session, I am going to discuss image-based questions in general surgery. Students, don't expect your teachers to spoon feed you everything. Teacher's role is only as a facilitator or guide. We can only show you the way, and it is your responsibility to travel that path on your own. Wish you happy learning. This is how to learn. Learn how to learn. That is the thing. So I want to show you after 2 weeks of learning everything, we tend to, remember only 10% of what we read, 20% of what we hear, 30% of what we see, 50% of what we see and hear, 70% of what we discuss with others, 80% of what we do, that is demonstration, whatever you are doing or in the wards, and 95% of what we teach to others. So the best way of learning anything is by teaching others. So I will be discussing these image-based questions under 9 modules. The first module is we are going to deal with abdominal wall hernias. What are the different causes for groin swellings? The various causes are inguinal hernia, both direct and indirect, femoral hernia, undescended testis, inguinal lymphadenitis, lipoma of the spermatic cord, encysted hydrocele, saphina varix, femoral artery aneurysm, psoas abscess, and femoral nerve neuroma. So, whenever you are going to deal with a groin swelling, you have to think of all these different possibilities. But the moment you are seeing a groin swelling, you have to ask the patient to cough and see. The moment you are seeing a neck swelling, you will be asking the patient to swallow like that. The moment you are seeing a groin swelling, you have to ask the patient to cough and you have to watch something. Okay. Cough impulse is positive, and if the swelling is above and medial to pubic tubercle, we are dealing with a case of inguinal hernia. Suppose cough impulse is positive, but the swelling is below and lateral to pubic tubercle, we are dealing with a case of femoral hernia. Suppose if there is no cough impulse, then you have to specifically look for some special characteristic features like if it is compressible, the swelling is compressible, we are dealing with saphina varix. If the swelling is having expansile pulsation, then we are dealing with the femoral artery aneurysm. If the swelling is transluminant, we are dealing with encysted hydrocele of the cord. If the swelling is firm or hard in consistency, we are dealing with lymphadenitis or lymph node enlargement. If the swelling is soft, okay, we are dealing with lipoma of the cord. So this you have to remember, this is a diagnostic algorithm. Coming to the case number 1. This is 25-year-old builder suddenly develops a golf ball sized, slightly tender lump in his right groin after lifting 20 kg of bag of sand. He stated that he felt a tearing sensation as it happened. He attends the accident and emergency department. So this is the case scenario, and these are the 4 pictures, and these are the 4 questions. See, in your exam, almost 90% of your questions are going to be case-based scenarios. They are going to give a case scenario like this, and they may ask you various questions. Of course, your questions will be in MCQ format, but I avoid MCQ because the best way of preparing for MCQ is not working MCQs, but you have to learn the concepts, the basic concepts you have to learn thoroughly so that in whichever way they are going to ask the questions, you should be able to answer. So here, see, in 10 MCQ, at least minimum 10 to 15 MCQs, you can answer by knowing these basic concepts. So the first question is, what is your diagnosis based on this scenario and this photograph, and why you are saying so? So naturally you are seeing a swelling in the groin area. So the answer is primary uncomplicated indirect inguinal hernia. That is the diagnosis. Why we are saying so? Because this patient developed the groin swelling after lifting heavy weight. But however, the diagnosis should be confirmed by further history and physical examination. So what are the other questions you will ask in the history? You can ask about cough impulse, reducibility of the swelling, whether patient is having difficulty in passing urine or difficulty in passing stools, a history of any chronic cough. So all these things will produce increased intra-abdominal pressure, and that is the root cause for developing indirect inguinal hernia. And you have to ask about history of previous appendicectomy also, because some of these patients, uh, what will happen during this appendicectomy? The iliohypogastric nerve will be injured, so the anterior abdominal wall musculature will become weak, and patient will develop direct inguinal hernia. So for that purpose, okay, you have to ask about the history of previous appendicectomy. What are the three types of indirect inguinal hernia based on this picture? So this is 1, 2, 3. So the first and second are, this is bubonoceal, this is funicular hernia, and this is total scrotal hernia. In the first two, types of indirect inguinal hernia, you should be able to palpate the testis separately, whereas in the total scrotal hernia, because this is a congenital hernia, the bowel will be surrounding the testis, so you may not be able to test this very well separately. This is the thing. So these are the three varieties. And question number 4 is, what surgeries are being done? See, here you are seeing one surgery, here another surgery. So, but for diagnosing a case of inguinal hernia, you need not do any special investigation. There is no need, because it's a clinical diagnosis. However, if you are having any doubt, then you can do ultrasound or even CT scan to prove the patient is having, the hernia, inguinal hernia. But normally we won't do any investigation because it's a clinical diagnosis. So in figure 3, you are seeing what is this surgery? This is a Lichtenstein's tension-free mesh repair. We used to put a after doing the herniotomy, you have to put the mesh, Prolin mesh, in the posterior inguinal wall, and you have to stitch it there. Above, you have to stitch it to the conjoint tendon. Below, you have to stitch it to the inguinal ligament. Okay, and here you are seeing two nerves. One is ilioinguinal nerve, another one is genital branch of genitofemoral nerve. So this is a open surgery, whereas here you are seeing a laparoscopic surgery. So you are seeing the peritoneal flap there, upper flap. This is the lower flap. So this is a TAP repair, transabdominal pre-peritoneal repair. But what are the indications for this laparoscopic repair? Only just because your patient is having inguinal hernia, you shouldn't do laparoscopic hernia repair. Only there is two medical, indications for doing laparoscopic repair. They are, number one, if you are dealing with bilateral inguinal hernia, or if you are dealing with recurrent inguinal hernia, then only you have to do this laparoscopic inguinal hernia repair. So here I have given the answers for all these questions, and I have given the reference also from 27th edition of Bailey, and I have given the pages also. So I hope that they might have already, shared these things, this image-based questions as a PDF format with all of you. So please read all these things. If you have any doubt, okay, you can ask me in a future class. I think I have been told that they will give time for you to ask me questions if you have any doubts. So case number 2, the 7-month-old baby was brought to the surgical outpatient clinic with an inguinoscrotal lump. He has had the lump for the past 2 months, but previously it appears only on crying. Over the last 2 days, has descended into scrotum and was unable to reduce. Baby started vomiting for 1 day duration. So these are the two pictures, and these are the 5 questions. Question number 1, what is your diagnosis and why you are saying so. With this clinical picture and this clinical scenario and this clinical picture, the diagnosis looks like obstructed indirect inguinal hernia, because the baby was having history of reducible inguinal hernia, which became irreducible for the past 2 days and developed bilious vomiting also. Complications for any inguinal hernia are it may become irreducible, obstructed, strangulated, incarcerated, or reduction en masse. These are the complications. What is the cause for the pediatric inguinal hernia? It is persistent processus vaginalis. Okay, what you are seeing in figure 1 and figure 2. In figure 1, what you are seeing, see, you are seeing the dilated bowel loops over the thing. This is a step ladder pattern you are seeing, and you can also visualize the VIP, visible intestinal peristalsis also you can visualize because of small bowel obstruction, and you are seeing a left scrotal swelling. Yeah, this is the hernia. This becomes irreducible. Okay, this becomes irreducible, but you won't develop, obstruction in case of, suppose if it is a omentocele, you won't develop obstruction. Only in case of enterocele, the baby will go for this intestinal obstruction. And what you are seeing here in this picture, this looks like a supine film, because if it is an erect film, we used to see the multiple air fluid levels. Here we are seeing only the dilated bowel loops. Probably the small bowel loops is dilated. So if it is dilated more than 3 centimeters, that is pathological, number one. And apart from dilated small bowel loop, you are also seeing the white line, which is crossing throughout the small bowel diameter. This is called valvulae conniventis or plica circularis. This is nothing but the mucosal fold in the small bowel. So these features or these signs are characteristic of small bowel obstruction. Okay, how would you manage this baby? So you have to explore by inguinoscrotal incision, and then after opening the sac, you have to assess the viability of the bowel. If the bowel is viable, you have to just reduce the hernia and do herniotomy. That's all. If bowel is non-viable, then you should do limited local resection of the bowel and end-to-end anastomosis with herniotomy. That is how you have to manage this baby. Case number 3, a 73-year-old man has had groin lump for some time, which he ignored. Over the last 3 days, it has become progressively more painful with redness of the overlying skin. He has not opened his bowels during this time, and yesterday he started to vomit. These are the 2 pictures and these are the 4 questions. So this is a swelling in the groin. You see the skin over the swelling is already erythematous. And in the second picture, you are seeing after opening the sac, you are seeing the discoloration in the bowel itself. So the diagnosis is quite obvious. We are dealing with a case of strangulated inguinal hernia, right-sided strangulated inguinal hernia. The cause is okay. We are seeing irreducible hernia. Number one, in irreducible hernia, there won't be any cough impulse. Okay, the swelling is the skin over the swelling is erythematous, and it is very tense and tender also. These are the reasons why we are saying it is strangulated inguinal hernia. What you are seeing in figure 1, I told you already. In figure 2, okay, this is the enterocele, you are seeing the small bowel, but here you are seeing the color change. Probably this is the area which is constricted. This is at the level of internal ring. Okay, how will you manage this patient? Okay, what you have to do after opening the sac, you have to assess the viability of the bowel by giving 100% oxygen or putting hot packs over the ischemic bowel loop. Okay, if the color returns to normal, we need not do resection. Otherwise, we have to do resection and end-to-end anastomosis. If resection has been done, don't do hernioplasty. You have to do only herniorrhaphy. Why? Because if you are doing resection, that area is potentially infected, and you should not use any mesh repair, because the mesh is a foreign body and it will get infected, and it is very difficult to eradicate this infection. And that is why whenever you are doing a resection in a case of strangulated inguinal hernia, you should not do hernioplasty, but instead you have to do only herniorrhaphy. Please remember this. And what are the special varieties of hernia you know? Okay, the dual, saddle or pantaloon hernia where you will be having both direct and indirect sacs. Sliding hernia, this is another variety. Richter's hernia, only the knuckle of the bowel will get strangulated. This is very common in femoral hernia. Littry's hernia, where the Meckel's diverticulum is the content. If the appendix is the content of the hernia, then it is called Amion's hernia. Madel's hernia is nothing but the W-shaped hernia, where the intestine will come out, go in, come out, and again it will go into the peritoneal cavity. That is what is called Madel's hernia. So case number 4, 60-year-old woman presented with a groin swelling which was below and lateral to the pubic tubercle. It became irreducible and skin over the swelling was erythematous and tender for 1 day. So these are the 2 pictures. These are the 4 questions. Here obviously you are seeing a swelling there. What is your diagnosis and why you are saying so? The moment you are seeing this patient is a lady patient, so you have to make sure whether this swelling is below and lateral to pubic tubercle or above and medial. Here in this case, this swelling is below and lateral to the pubic tubercle and it is irreducible also. The skin over the swelling is already erythematous. So we are dealing with a case of strangulated femoral hernia. Okay. Why it is common in female patients? Okay. Why it is common? Because the females are having wide pelvis, resulting in roomy femoral canal and the weak ligaments because of repeated pregnancy. It's more common in multiparous women. What are the complications? The commonest complication is the Richter's hernia because the femoral ring is surrounded by rigid ligaments on 3 sides, unlike the internal ring which is surrounded all the sides by only by muscles. The dangerous complication of femoral hernia is torrential bleeding due to injury of anomalous obturator artery. So while reducing this hernia, it should not injure this anomalous obturator artery, otherwise no, it will bleed to death sometimes. So you have to be very careful. And how will you manage this case? There are 3 approaches for surgery: high inguinal or Lutetian's incision, low inguinal or Lockwood incision, depending on the site of the femoral hernia. Whereas you should use the McEvody's vertical incision only for strangulated femoral hernia. Case number 5, this is a 65 years old obese multiparous woman developed a swelling over her umbilicus for the past 3 years. Initially, it disappeared when she lay down and obvious to her only when she got up and walked around. Now, for the past few months, she noticed the swelling all the time and it was painless. See, obviously, the diagnosis is quite obvious. What is your diagnosis and why you are saying so? Patient is also having a cough impulse. So, this is obviously a case of umbilical hernia. Okay, how it differs from pediatric umbilical hernia? This is a adult umbilical hernia. This is a pediatric umbilical hernia. The adult umbilical hernia is also known as para-umbilical hernia. The pediatric umbilical hernia, actually, the bowel is protruding through the weak umbilical cicatrix. Whereas here in the adult umbilical hernia, the bowel is not protruding through the weakness in the umbilicus, but in the weakness in the linea alba, either just above or below the umbilicus. And that is why it's called para-umbilical hernia. What is the commonest complication? The commonest complication is patient will be going for obstruction and eventually strangulation, and that is why you have to operate these patients. Should operate it once the diagnosis is made electively. You have to operate this patient before the patient is going for these complications. Yeah, you have to electively, but you have to operate as early as possible. What is the management? Previously, we were doing Mayo's repair for this, that is the double breasting operation, but nowadays we are not doing that. We are doing either open or laparoscopic IPOM, that is intraperitoneal onlay mesh repair is what we are doing nowadays. Case number 6, 72-year-old lady has had abdominal surgery in the past for duodenal ulcer perforation. She presented with a swelling over the scar for the past 3 years. The swelling is now only partially reducible. These are the 4 pictures and these are the 5 questions. Question number 1, what can be seen in these pictures? You are seeing in this and this picture, you are seeing a swelling over the scalp. Okay, only after this surgery is for due of ulcer perforation. Okay, so this is obviously this is a case of incisional hernia. What factors may predispose one to develop this condition? Okay, the basic is the poor wound healing. That is the cause for this incisional hernia. There are some patient factors like patient may be malnourished, old age, patient may be a malignant patient, immunocompromised patient, patient is getting steroids or infection of the wound, or patient underwent some radiotherapy, or patient is a obese patient. These are all patient factors. But there are some factors, surgeon's factor, because surgeon is using some poor surgical technique or poor suture selection. Suture may, because of that, suture may break up. So if you are using a catgut for closure of the laparotomy, definitely you are going to get incisional hernia. So that is why for all laparotomy wound, you should use only non-absorbable suture material. What are the contents of this incisional hernia? Any visceral organ, most commonly momentum, small and large bowel. Question number, what are the indications for emergency surgery? So if patient is developing pain, irreducibility, intestinal obstruction, or signs of any peritonism, which suggests ischemia, then okay, you should do surgical exploration. What is the current treatment for this incisional hernia? You can do either laparoscopic IPOM, or you can do open also, that is intraperitoneal onlay mesh repair. If the defect is very big, then you can do what is called Ramirez component separation. This also you must do. You have to, in component separation also, you have to separate the 3 muscles. You have to incise and you have to, undermine these muscles, and you have to put a very big mesh so that, okay, it won't recur. This is what is called component separation. Case number 7. 65-year-old man has developed a swelling below and lateral to the umbilicus on the left side for the past 3 months. Cough impulse is positive. The swelling is reducible. These are the 4 pictures you are seeing. Question number 1 is, you are seeing a swelling just at the level of umbilicus on the left side. Okay, cough impulse is positive. What is your diagnosis? With this clinical scenario and with this picture, the diagnosis is uncomplicated Spigelian hernia. And what is the second question? What is the etiopathogenesis of this problem? It is a hernia through the defect in the upper neurosis of the transversalis abdominis. It classically occurs at Spigelian point, which is the junction of linea semilunaris and linea semicircularis. Okay, you can see it here. This is the linea semilunaris, the lateral border of the rectus abdominis. And this is the linea semicircularis, okay, where the posterior rectal sheath will become deficient below this area. This is arcuate line. So the junction of these 2 lines, the linea semilunaris and linea semicircularis, where usually you develop the Spigelian hernia. What is the commonest complication is strangulation. And how will you, manage this case? Because of fear of strangulation, it should be electively repaired once diagnosed. Either you can do open or laparoscopic mesh repair. That is what you are seeing in this. This is open mesh repair. This is also open mesh repair. You can do it laparoscopically also. So case number 8, a 55-year-old male patient, case of carcinoma rectum, underwent AP resection with permanent end colostomy. For the past 3 months, he developed a swelling around the stoma, which is having cough impulse. That is, cough impulse is positive. See, this is the colostomy, and you are seeing this swelling also around the stoma. What is the diagnosis? Diagnosis is very obvious. This is a parastomal hernia. Okay, parastomal, what is the treatment? If it is a temporary stoma and the purpose of this stoma is over, you can close the stoma and you can go for re-anastomosis. If the stoma is a permanent one, like our case, then you can reside the stoma, but this may not be ideal. Various open, suture and mesh techniques have been described. Meshes are best placed in retromuscular place, that is the sublay mesh. Prophylactic prolin mesh incision at the time of creation of the stoma itself. See, while you are creating the stoma, then itself you have to put this is the mesh around this is the stoma. So this is what you have to do.